Greeting everyone, this is Dr. Hassan and I would like to share with you this ultrasound case of this week. I will call it abdominal pain made easy with ultrasound. This is a 14-year-old boy who is known case of sickle cell disease and he's known to have gallstones as well. He presented this time with right upper quadrant pain for 2 days for the first time. He was having normal vital signs. He was afebrile. He was sitting but he was in pain. And he was mildly jaundiced. Abdominal exam shows tender right upper quadrant and positive Murphy sign. His lab shows total bilirubin was 5.9, mainly indirect, and he was having normal liver function test, normal lipase amylase, but he was having marked leukocytosis. So the clinical diagnosis here is very clear and you don't need to be smart to figure it out. It is acute cholecystitis. So what is the role of ultrasound here? In fact, ultrasound might increase your likelihood or positive likelihood ratio of your diagnosis and will confirm your diagnosis. So let's see the ultrasound. We started with longitudinal axis, placing the curvilinear probe in the right midclavicular line just below the ribs. And this is the longitudinal axis of the gallbladder. What you notice here is that the gallbladder is filled with echogenic materials, which is sludge. And there are multiple tiny hyperechoic shadows inside the gallbladder, which represent very tiny multiple stones. And what you notice also, there is thick gallbladder wall. You see the gallbladder wall here is thick. And there is anechoic rim of material around the gallbladder, which is pericholecystic fluid. Now if we move to the short axis, we place the probe horizontal plane just below the ribs in the midclavicular line, and we demonstrate the short axis or cross-sectional of the gallbladder in short axis. This looks like oblique, it is not true short axis, but demonstrate there is again, this is the gallbladder filled with echogenic material with again tiny hyperechoic shadow which is the multiple stones, and there is thick wall and pericholecystic fluid as well. Now if we measure the wall thickness here, the short axis is better for measurement of the wall thickness. Here it measures around 5 millimeter. So again it is increased and there is clear pericholecystic fluid. Now next step to look for the common bile duct and to see whether it is dilated or not, indicating common bile duct stone or obstruction. Here you will see two longitudinal structures, anechoic structure. So one of them is the portal vein and one of them is the common bile duct. To confirm that, you should apply the color Doppler and to see there is flow in the portal vein and there is absence of flow in the common bile duct. And now if you measure the thickness of the CBD from the inner to inner wall, it is less than 7 millimeter here, which is normal caliber. So diagnosis here is very clear, acute cholecystitis. So the patient was admitted, managed with antibiotics. After a few days, he underwent elective laparoscopic cholecystectomy and discharged in good condition. Someone might come and says that ultrasound might not be necessary here because the diagnosis was very clear clinically, so you don't need ultrasound on the day of presentation. Practically speaking, not always gallbladder disease comes straightforward. Sometimes they present with atypical pictures. Let's take this patient who is 33-year-old male. He presented with mild epigastric pain since 3 days. I saw him initially in the adult ER. He was having mild epigastric pain, so I sent him to the adult clinic to be seen there because it is not an emergency. Seen in the clinic, he was prescribed antacids and ranitidine and discharged. But seems that the patient was not satisfied, so he came back to me asking for more investigation. Well, I said, okay, let's see him again, let's examine him again. Again, there is very mild tenderness in the epigastric area. So I thought, let me do bedside ultrasound just to make him more satisfied. I was surprised to find this. This is the gallbladder, and there is thick gallbladder wall and seams in layers as well, which represent gallbladder wall edema. And there are multiple hyperechoic shadow in the gallbladder with a caustic shadow, black shadow, which represents stones, multiple stones, thick wall. Now, this is another view. Again, this is the gallbladder wall, thick, and there are multiple stones with a caustic shadow. If we go to other view, it is very clear here, the wall edema, and there is pericholcystic fluid as well, and there are the multiple stones. So I was surprised to find that this is not straightforward gastritis, and this represents either cholecystitis or something more in the pancreas. We tried to look for the common bile duct. It is very clear here that it has diameter almost equal to the portal vein. So if you find common bile duct that's equal in diameter to the portal vein, it's almost dilated. If we apply color Doppler here, you will find this absence of flow in the common bile duct, confirming that this is the common bile ducts, and it was measuring around 8 to 9 millimeter. So the diagnosis here, acute cholecystitis with CBD obstruction and possibly pancreatitis. Then later I was surprised that his lipase came 8500 with moderate raised LFTs, and white blood cell was normal. Who says ultrasound will not help in such case? Now let's take another more case which is very common in the elderly. This is a 60-year-old lady with right upper quadrant pain. She presented to the adult emergency department vitally stable, but she was looking ill. Examination, tender right upper quadrant with positive Murphy sign. Her white blood cell, LFTs, lipase all came normal. So the clinical diagnosis here was acute cholecystitis, and she was referred to the general surgery for admission. But unfortunately the GS saw the patient and they thought it is not cholecystitis because all her labs were normal, so how comes this is cholecystitis? And here comes the problem. As emergency department resident or physician, you will find it is very difficult to convince others that this is cholecystitis. So where the patient should go? Medical. Once they find there is tender abdomen, they will refuse to see the patient, or at least they will refuse to admit under medical, because they know the likely that this patient will deteriorate and needs probably surgical intervention is high. So better to be free from surgical side first. And we know that acute cholecystitis, not always they come with typical signs, and this is a study done in the Annals of Emergency Medicine 1996. They found that people admitted with acute cholecystitis confirmed by histopathology later, they found that initial presentation in the emergency department, they had no fever in 70% of the patient, and 32% of them they had no leukocytosis, and 28% of them they had neither fever and leukocytosis. So fever, leukocytosis are not always there, especially in the elderly. This ultrasound was done by our colleague Dr. Noura, and she found there is pericholcystic fluid, distended gallbladder, and there are multiple tiny hyperechoic stones with a caustic shadow. So the diagnosis here was confirmed that this is acute cholecystitis, and general surgery, they called radiology and they confirmed the same finding. So she was admitted later on under general surgery as acute calcular cholecystitis. So the final message here, that the diagnosis is mostly always clinical. Ultrasound will give you the most benefit if you combine or add it to your clinical suspicions. And ultrasound helps rule in the diagnosis, or it might reduce the likelihood ratio of the diagnosis. So it's not always the picture is easy clinically, and we have seen a lot of patients who present atypically and later on found to have severe form of acute cholecystitis or even biliary pancreatitis. Thank you very much.